Thanks very much. Good morning, everyone, and thanks for your introduction, Joe. Did you say nearly spanning 4 decades? I'm afraid it is spanning 4 decades, but we won't dwell on that any more than your age, Joe. So, get this right first. What I wanted to talk about first, or dwell on, maybe it touches on Joe's mention of Connor, was the number of fatal overdose, the number of fatal overdose deaths in 2018 was 1,187, and obviously, we all know this is the highest in Europe. But I think it's worth reflecting, as we will do today, on the scale of this disaster, as we have to call it. I also did a count of the number of fatal overdoses since 1996, and the figure comes to over 11,500. Now that's, as we described certainly the year before last, this is the size of a town such as Montrose, Stonehaven or Stranraer, and I think we have to continually to push for the fact that the scale of this is actually huge compared to other countries, and I'll come on to that. Obviously this has been described as a national tragedy, a national shame, and also as a national emergency and a national public health emergency. And it surely cannot be seen as anything other than an emergency. What we've seen, obviously, is a continued rise in the number of overdose deaths, and what we'll also see within this is that the bulk of that rise is driven by those aged 35 and over. And so about 900 of those deaths of the 1,187 were in the over 35s, but what we're also seeing now is the emergence of an increase in deaths in the under 35s as well. As a percentage, they're not really changing, but obviously because the numbers are going up, that we're seeing an increase in that, if you like, younger generation, which of course I'll come on to later in terms of those issues around further generations. So what I wanted to speak around was why is the situation so catastrophic? What we're doing and what we need to do. And in terms of the first point, what was interesting, I suppose, and useful in many senses, that when the drug death figures were launched in July, we had a lot of international media interest in the deaths. And that was really probably the first time that there was actually interest more widely, which can only, I think, add to the pressure to deliver change. And we had, say, the likes of the New York Times asking, why is Scotland different to everywhere else? And obviously that's a complicated question to answer, but I think fundamentally poverty and inequality play a huge part in that. And I've said this often, and I think it's worth repeating, that you look at other countries such as the Netherlands or Sweden, two countries with very different drug policies, but with very much smaller drug problems, and obviously even smaller fatal overdose deaths. So you have to ask about the whole issues around the environment. Obviously we also have issues around welfare reform, and trauma has now increasingly been recognised as it should be as such an important issue, particularly childhood trauma, but not just childhood trauma, also adult trauma. Polydrug use, we know has been a feature, since the 1980s, but increasingly, I suppose, we're seeing the further increase in the use of street benzodiazepines, and also in various parts of the country an increase in cocaine use alongside opiates and depressant drugs. And then we have issues around the ageing population, as we know about, and that the broad term around some of those range of health conditions that people are experiencing are described, I suppose, as multiple morbidities that people might have. So all of those factors together and others obviously in terms of treatment issues, and I'll come on to those, has led us to the situation we're in. But we can't just deal with the situation we're in without recognising actually what the drivers for that situation are, and particularly looking at actually what we might do to limit issues in the future of the next generation. So, what are we doing? And I just wanted to cover briefly. Austin has mentioned the Staying Alive document, and there's a workshop that Murray Beth from SDF will be leading on this afternoon. So we had that document. We've also had the drug-related deaths rapid evidence review conducted by Eleanor Dickey that was published, I think, in 2017, which went alongside the work that we'd done around the over 35s. We've also had the drug and alcohol strategy, rights, respect and recovery, published at the end of last year. We now have the emergence of a new public health body, and they've recognised the need for a focus on drug and alcohol issues as part of that. And we have the announcement in April of the expert group to look specifically at drug-related deaths, and the remit of that group, the Public Health Minister will convene an expert group to examine the key drivers of drug deaths and advise on what changes, either in practice or in the law, could help save lives and reduce harm. Now that group is due to meet, I think, the first meeting in the middle of September. And we've also had the Dundee Drug Commission report that came out on the 16th of August. Now, I was a member of the Dundee Drug Commission that produced this report, and I think there was at least one other member of the Commission in the audience. And I just wanted to bring your attention to this report, because I think it is really insightful and has dug very deeply into the situation in one part of Scotland, and I think other areas could do well to look at that report. Hopefully the situation in other parts of Scotland is not as severe as it is in Dundee in terms of some of the responses, but certainly there are lots of lessons in there that are usefully learned. So what I wanted to do was just cover some of those very quickly. And the key conclusion of the report was that we couldn't hide the fact that actually all of the recommendations that we're putting in place are challenging to implement, but that actually the key issue has been the lack of leadership in Dundee, and that is so evident that there hasn't been the focus on it. The Dundee Partnership is committed to delivering the changes and recommendations in the Dundee Drug Commission, but obviously that particularly is looking at making sure that every life matters, and more positively that every life matters, but also that every death also matters as part of that. So I'll just pick up on a few of the recommendations, and this is the first one, is around issues around leadership, as I said, which is the crucial one. And what this also covers is a lot of the issues to do with actually the ability of alcohol and drug partnerships and the integrated joint boards, the health and social care structures, to actually hold services to account for what they're doing. And particularly in the Dundee context, it was the integrated substance misuse service, where there were particular challenges about the delivery of that service, and that was we heard a huge amount of evidence as part of that report. A lot of it was pretty harrowing to listen to in terms of people's stories, and also, just as Joe recounted a fatal overdose death, we also heard of a number of cases where services had failed people, well, a significant number of cases. So, as I said, this was the key recommendation, and for those of you that don't know the detail of that, the Integrated Substance Misuse Service is the main NHS addiction service within Dundee, and the report states very clearly that the provision of services currently offered by the Integrated Substance Misuse Service should be delivered through a development of a whole system model of care, and should be structured via a joint and equal partnership with both primary care and the third sector. and the key purpose of utilising the unique strengths of all partners. Now, what we saw in the Dundee context was a complete disconnect between the voluntary sector services and the NHS services, but not just NHS services. Even within NHS services there was a disconnect, and actually the level of GP involvement in the care of people with drug problems in Dundee was virtually non-existent. So there's a huge task in terms of shifting the current model to something different, and what we saw was, I suppose, there were lots of vested interest protecting the status quo in terms of how things are currently. So as I say, that report is really worth having a close look at in terms of the lessons we can learn from elsewhere. What was also interesting was that at the beginning of the discussions, the issue was around, or the service was talking about problems of retention and not being able to move people on. We asked lots of detailed questions about things like did not attend rates, unplanned discharges at the start of the work, and it was only late on that we got that information. So in Dundee, for the previous year, there was 452 unplanned discharges, and that's with having 1,300 people on OST. So the churn of people within the system was huge, and actually that wasn't recognised initially by the planning committees and structures, or by the service themselves. So we have to get much more real about what is actually happening on the ground and what we're actually doing. But I just put this one in, it maybe goes back to the point, this adds a bit more detail on those issues for the Integrated Substance Misuse Service, and it talks specifically about improving retention and having an unambiguous no unplanned discharges policy. This is what Norway has introduced as part of their drug death strategy, and certainly it's something that we would implore areas to look at. Obviously issues around optimised OST, psychological treatments, assertive outreach, etc., which I'll come on to some of that in a minute. And also just wanted to touch on this recommendation, which is a much broader one, but touches on that point about we're seeing an increase in fatal overdoses among the under 35s, and looking at all those issues of intergenerational problems and the need to do far more to actually stop a future generation emerging. And that was specifically looking at better family support to vulnerable families. So that was really a lot of those issues in terms of committee structures, recommendations, and what we've been doing. Just to really conclude on really what we need to do to make a difference. And I think first of all is this issue of recovery. We all know is a big issue in terms of defining that. We've strongly argued that the recovery should be viewed in terms of improving people's quality of life, and also ultimately the right to life. Improving OST, and Austin mentioned that at the start, issues around reducing stigma of OST in particular, which has now become massive in the last 10 years, or maybe more than that, in a way that it certainly wasn't when it was initially introduced. All the issues around supply of naloxone, and also drug consumption, which I know Garth is going to touch on in his presentation. But we need, as part of that, to recognise that one drug consumption room in Glasgow is not the answer. It's part of the answer, and obviously we need to have those across the country, which I'll come on to. So, just to touch on OST, naloxone and drug consumption rooms, the first thing, and it recounts, I suppose, a lot of those issues in the Dundee report, issues of poor access and people waiting months in the community or prison for OST, and certainly we're here in the prison context that 6 weeks is the norm for access to OST. In the community service, it can be very variable, and obviously is masked by the 3-week waiting time, which actually doesn't measure access to OST. It measures access to all treatment. What we've also observed more recently is this issue of suboptimal dosing, and increasingly seeing that that could be as high as 50% across those on OST, and the figures for those on OST, I think in total across Scotland was something like 26,000, in a year. So we don't have that precise figure of numbers on OST, but obviously we're talking about considerable numbers of people on suboptimal doses, and obviously the potential impact of that on people's health and risk of overdose. So, as I've said, poor retention and high levels of unplanned discharge. Again, that's variable across the country. There are some much better areas than others. Lack of choice regarding OST. Obviously, we've got the new slow-release buprenorphine preparation, and we would argue for a fuller range of OST treatments. And it's too often, like the Dundee experience, it's not linked to the wider support in the way that it needs to be. What we've seen certainly emerging is some really good practice across the country in terms of things like same-day prescribing, greater choice in OST, optimal dosing, an increase in look at issues around assertive outreach, and hopefully the emergence of policies around no unplanned discharges. But the challenge, of course, is to make this the norm and improve accountability of OST through the ADP and the integrated joint boards. So we have, certainly if the Dundee experience is anything to go by and experience elsewhere in Scotland, a long way to go to deliver that. This I just put this up maybe because we'll have this up on the website, is a useful slide which just shows the I'll just get a drink of water. I think I'll get a drink of water, John. Just shows the protective factors of people being on OST, and obviously then people, the high risk time is actually people going onto OST and then leaving OST, and obviously what we're seeing, certainly in the Dundee context and other places, is significant numbers of people going in and out of OST rather than staying on it long enough for it to make a positive impact on people's lives, both in terms of keeping them alive and more widely in terms of their improved quality of life. So with regard to naloxone, obviously that has now moved to being funded locally. We need to see a continued level of funding locally, and ensuring that the supply of kits is prioritised. We need to support peer supply of naloxone. Now, at the moment, as far as we're aware, Glasgow remains the only example of actually peer supply of naloxone. Now, that's not difficult to actually deliver with appropriate support, and it means is that we're actually reaching out and accessing more people to ensure that everybody is supplied with naloxone, and that's obviously what we need to be looking at. And ideally, we'd want a target of 90% of the target group trained, supplied, and carrying naloxone. Now, that's we're quite a long way off that, clearly, but we've made some good progress in terms of naloxone, but we need to continue that. Briefly, and as I said, Garth will talk, I think, in more detail about the British Columbia experience around drug consumption rooms. But our frustration, I suppose, is that this has become something of a constitutional issue and a political football. And I think the challenge is recognising, as I've said, is that one drug consumption room in Glasgow will not impact significantly. What we would need to do is actually deliver that drug consumption rooms across Scotland. But we're not, obviously we're a long way from that, and I think the arguments are that we should concentrate really on improving things that we have the ability to do just now, rather than obviously having an idea around what drug consumption rooms might look like and what they might do, but we have to focus on improving what we have control over now. That's both OST, naloxone, and wider support. And obviously this is from the Dundee example, but I think more widely, is that this requires local and national leadership and a need which does call out unacceptable and inhumane practices, follows the evidence base, and ensures that appropriate level of resourcing enables good practice to emerge as the norm rather than the exception. So that's what we need to strive towards, and hopefully we have to move far more quickly now to that situation and deliver that. And as we've heard, this is a public health emergency, but we need urgent action to deliver that, and that's where all of you and we have a role to play collectively to ensuring that can happen. Thank you very much.